Hi, so we're going to talk about the clinical pharmacology of antiretroviral drugs, which are formulated as long-acting agents. These are my disclosures. So what is a long-acting drug? What do we mean when we say long-acting? Why would we use long-acting agents? And when we look at drug concentrations of long-acting drugs, are these the same for everybody? Are we studying the right populations? Are we studying everybody who needs these drugs? And there's been a lot of talking about the pharmacokinetic tail of long-acting drugs. Do we need to worry about it? And what about drug-drug interactions? Do we need to worry about them? Do they disappear when a drug is formulating as a long-acting agent? So hopefully we're going to answer some of these questions. So a long-acting drug is a drug that is slowly absorbed in the systemic circulation and is slowly eliminated, excreted. It persists in the circulation and tissues for a prolonged period of time and is also effective for a long period of time. The objective of a long-acting drug is to be administered less frequently than daily, than ideally once a daily, which is already a good objective that has been achieved in antiretroviral therapy. But we can clearly do better, and this is where a lot of research is focusing at the moment. So long-acting drugs can be given orally and maybe with once a week, once every other week administration, or even longer, parenterally, so either intramuscularly or subcutaneously, every 1, 2, 3, 6 months, or they can be administered by an implant or a device, and these may be changed, renewed every 6 or more months. So the benefits of a long-acting drug is that they increase the choice for the patients, and they increase the convenience and the health privacy if people don't have to take pills every day. They help and simplify adherence, and sometimes they may reduce the amount of the active drug that is administered. This slide shows the concentrations with the blue continuous slide that a long-acting agents would achieve in plasma compared to those that are achieved when a drug is administered orally once a day. So in terms of the concentrations window, therapeutic window, the rule is the same. Drugs must be above the minimum effective concentrations to avoid to fall in a area where concentrations are too low to be efficacious, and must be below a maximum safe concentrations to avoid toxicity. But this would be achieved over a longer period of time than 24 hours. So how can we deliver long-acting drugs? As I mentioned, there are many different ways, some of which are either oral, by pills, either because the drug is nano-formulated, for example, or either because they're contained in a particular device that persists in the gastrointestinal tract for a long period of time. They can be given subcutaneously, they can be given by implants or other devices, or they can be administered intramuscularly. And it is what we're going to mainly focus over the next 15-20 minutes, long-acting drugs that are administered intramuscularly. And the reason why I'm talking about this is because of the two drugs that have been studied over the past few years and are now becoming available for the treatment of HIV infection and are rilpivirine long-acting, ercabotegravir long-acting, that are combined and have been studied again in phase 1, 2, 3 studies and are becoming available for the treatment of HIV. So importantly, we have solid phase 3 data. Atlas and Flare are the two randomized open-label international phase 3 studies that have demonstrated non-inferiority of switching to monthly intramuscular injection of cabotegravir plus rilpivirine long-acting versus current antiretroviral regimens taken orally once a day. So we know that the combination of rilpivirine and cabotegravir intramuscularly is non-inferior to oral treatments. This slide shows the concentrations of cabotegravir and rilpivirine long-acting when are administered every month in ATLAS and in FLAIR. So importantly, there is a lead-in oral period of approximately 6 weeks. And this is because of safety requirement to make sure that people are not allergic and tolerate cabotegravir and rilpivirine. And then there is a first injection that you can see is at the beginning of the graphs when the concentrations are indicated, the beginning of the concentrations curves are indicated, which is a higher injections to favor the loading of the drug, to favor the achievement of therapeutic concentrations of the drug. So cabotegravir is given 600 milligrams, and rilpivirine is given 900 milligrams. And then a lower drugs of cabotegravir 400 milligrams, rilpivirine 600 milligrams are given every month. And this is what you see in terms of what concentrations are achieved. And the important thing is that these are indicated as median and 5th and 95th centile, and are well above the protein binding corrected IC 95. However, there's more to say about the concentrations, about the drug exposure of long-acting agents. So in terms of cabotegravir, the pharmacokinetics may vary because of sex at birth and BMI. 4 weeks following the first injection, the median cabotegravir concentrations were lower in females than males by 40%. However, interestingly, at week 48, concentrations were slightly higher in females than in males. And for what concerns body mass index, 4 weeks following the first injection, median cabotegravir concentrations were lower in individuals with body mass index above 30 by 46%, compared to those with a BMI below 30. But at week 48, this difference wasn't present anymore. And for what concerns rilpivirine's differences between different sexes and a baseline BMI were not observed. Importantly, there were a good percentage of women that could be studied in the ATLAS and FLAIR studies. So 20% of women, 20% of participants were women and 36% were Black or African American. And these are the concentrations that were achieved in women versus men on one side of the graph, one side of the slide. And you can see again that women have lower concentrations at the beginning and higher concentrations at the end of the graph at week 48. And similarly, people with high BMI higher than 30 have lower concentrations at the beginning of their therapeutic history with long-acting agents. However, in terms of pharmacodynamics, there were no difference in virological response between women and men. Both women and men achieved high rates of virological response in ATLAS and FLAIR. Worth mentioning the next step, which is ATLAS-2M. So ATLAS-2M is a clinical trial that compares administering cabotegravir rilpivirine long-acting once a month versus every other month, and administering the long-acting agent every other month was non-inferior to administering them once a month, was well tolerated with low-grade injection site reactions developing, and was preferred by study participants. And we're very much looking forward to see the PK data for Atlas-2M to look at the concentrations of the drug and what happens to them. So what about if someone who is administered long-acting agents for the treatment of HIV, misses an appointment and doesn't show up to the clinic, to the pharmacy, to receive the next injection when the injection is due? So this is what we mean for PK tail. The concentrations of the drug will inevitably decrease and reach concentrations that are around and then below the minimum effective concentrations. So there will be a period where there's not enough drug to inhibit viral replication. The virus will start to replicate and the drug is still present, but again at low concentration. So we're in the context of selective pressure with viral replication. And therefore, we are observing a situation where there's a high risk for developing resistance to the drug. And this is known from either animal studies for cabotegravir, animals that were administered cabotegravir, stop cabotegravir administration, when cabotegravir administration was stopped, and then they received, they were infected with CIV, and when the virus replicated in the presence of the drug, developed integrase inhibitor associated mutations. And also for rilpivirine, we actually had a case in Chelsea Westminster Hospital when we ran the phase 1/2 PrEP study where an individual was infected by HIV during the rilpivirine long-acting study and developed mutations during the study, mutations to NNRTIs. So we know this is possible, and that's what we will have to try to avoid in clinical practice. So the pharmacologists developing these drugs have are suggesting some important strategies called bridging strategies to ensure that if people cannot present to the clinic when they need a second injection, there are some alternatives, some solutions, some remedies that we can suggest in order to avoid that the concentrations achieve low levels so that are at risk of developing resistance. And oral bridging is one of these strategies where, again, someone can take oral therapy between one injection and the other if the interval is longer than suggested. And this has been done by modeling. So if an injection, so for example, if the fourth injection, if you look at the bottom two graph, if the fourth injection is delayed by 4 weeks, you can see that the oral bridge in black would allow to overcome the risk of achieving concentrations that are too low to work, to inhibit, to maintain an undetectable viral load. Similarly, at AIDS 2020, data were presented for rilpivirine. Bridging strategies are possible with oral rilpivirine, and again, an oral bridge with 25 milligrams of rilpivirine once a day, followed by a 6 milligrams injection of rilpivirine long-acting. If the time between injection is less than 2 months, it can be implemented, or with 9 milligrams if the time between the injection is more than 2 months. So this is good advice that we will adopt in clinical practice. So what about drug-drug interaction? So when you don't administer a drug orally, there are some potential drug-drug interactions that are overcome, that are not going to happen. Some of the drug-drug interactions mechanisms that occur at the level of the gastrointestinal tract are when a drug is absorbed by a pH-dependent mechanism, drug chelation, first-pass metabolism, gastrointestinal tract transmembrane transporters can be behind drug-drug interactions. Well, all of these mechanisms are not a problem when a drug is administered intramuscularly. However, drug-drug interactions are not completely disappearing for long-acting agents because these drugs are still metabolized by the liver, for example, or others may be still eliminated by the kidney. So in this case, it's just quite difficult to study drug-drug interactions because of the long half-life and the persistence of the drug concentrations. Study designs might last many months and are difficult to be implemented in vivo. Therefore, modeling and PK/PD strategies might be useful to understand drug-drug interactions for long-acting agents. And this is what the group from the University of Liverpool did. They looked at they modeled the concentrations of intramuscular cabotegravir and rilpivirine in the presence of a strong inducer rifampicin, and they showed that the concentrations of both drugs would remarkably be decreased during co-administration with rifampicin. So we focus mainly on rilpivirine and cabotegravir because they are the first drugs that have been developed, and I think we will learn a lot. We are learning a lot already from clinical development, and we will learn a lot when the drugs are implemented in clinical practice. And this will allow us to be more knowledgeable when other long-acting antiretrovirals will be available. Discovering units are focused very much on giving less drugs and looking into new mechanisms of action and developing long-acting antiretrovirals. So we know about other long-acting drugs that are being developed. So Islatravir, for example, is a nucleoside reverse transcriptase translocation inhibitor, and it has been studied following the placement of an implant in healthy volunteers, and the concentrations achieved have been modeled to show that 62 milligrams implant can lead to concentrations above the threshold for at least 12 months. So this would be fantastic for exposure prophylaxis and also for HIV treatment when a drug that it can be combined with would become available. Another very promising long-acting drug is Lenacapavir, which is a first-in-class capsid inhibitor, and it is being developed as an oral formulation, but also as a subcutaneous long-acting formulation. And this graph shows the pharmacokinetic results of the study, of the phase 1 study. And you can see the concentrations in healthy volunteers, and you can see that this formulation supports 6-month dosing because the concentrations were maintained above the target for up to 26 weeks with a remarkable inhibitory quotient. So to conclude, the development of injectable and implants and other long-acting formulation is indeed exciting, and it is worth to learn about the pharmacokinetic tail, about different population exposure, about bridging strategies now as much as we can, because this is hopefully the future of HIV treatment. And also remember that by skipping the gastrointestinal hepatic first-pass metabolism, drug-drug interactions are likely to be fewer for systemically administered drugs, but they're still present, and modeling can be important when these drug-drug interactions are difficult to study in vivo. And I focused on the pharmacokinetic of the drugs. I didn't talk about implementation challenges. I think we will face a few over the next few years, but hopefully, again, we will learn to use these drugs, and the implementation challenges into clinics will be overcome. Thank you very much for your attention.